Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Kathrin Berg.
What constitutes a traumatic brain injury in a child? How is it diagnosed and how is it treated? We have the Traumatic Brain Injury Program lead here tonight, and she is from the El Paso Children's Hospital and Texas Tech Health El Paso, and we're going to discuss all of these things and even more. Thank you for coming back. This program is underwritten by El Paso Children's Hospital. We also want to thank the El Paso County Medical Society for having this program since 1997. I'm Kathrin Berg, and this is the El Paso Physician.
Neither the El Paso County Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. This evening we have with us Amanda Chiao, who is the assistant professor at Texas Tech El Paso and also the pediatric audiologist at El Paso Children's Hospital. And we're going to be talking about pediatric trauma brain injuries in the Borderland. So it's a difficult subject to talk about. There are so many different aspects to this and ancillary strings that we're going to talk about. So I thank you so much for being with us. I remember that you were here several years back, but I understand that you have 20 weeks worth of a baby in your belly.
I do. I just came straight from my OB appointment.
So thank you for being here because, of course, this is what mommies know. You're climbing a mountain every single day when you're pregnant.
Yes, it feels like it.
Yes. So if you know someone who's pregnant, give them a break. Just saying. Thank you so much for being here.
Course.
But we're going to be talking about, again, treating pediatric traumatic brain injuries in the Borderland. And it's like, well, it's not a brain injury. It's not brain surgery. But a lot of times it is. So I would like for you in this area, in this subject, if you can kind of explain what it is that you do all day, every day in this realm to kind of help the audience get to know you a little bit better.
Yeah. So I'm just one piece to a really big, team. And to do, in my opinion, management of pediatric TBI, you really have to have a multi-integrated team. So I'm a pediatric audiologist. What I focus on is really addressing a really big component of pediatric TBI, which is the signs and symptoms of dizziness and visual disturbances. So as an audiologist, I diagnose. I also can provide some rehabilitative support. Just because of my training and my experience, I used to work at the University of Nebraska-Lincoln, where I really trained with student athletes at the D1 level for 5 or 6 years.
Oh, wow.
So I really learned what recovery looks like and that children with traumatic brain injury can recover. And they should be able to go back to their activities, their sport, their life. And if you do it right, that can happen. So for me, that's kind of my role. But I'm just one piece. So our teams at Children's, but really any major pediatric TBI team consists of pediatric, sports medicine or pediatric neurosurgery, pediatric neurology, behavioral health to support more of the mental health aspects that come with pediatric TBI. And then, of course, we would be nowhere far in recovery for traumatic TBI. We didn't have our occupational and physical therapists and sometimes speech therapists.
And with these kind of injuries, and you were talking earlier that you do a lot with the rehab, and that's where the magic happens. And that's where you see things coming back. And so I'm very happy that we're going to concentrate a lot on that today.
Yeah.
One of the big questions is, when you say traumatic brain injury, that's like traumatic, right?
Yeah.
What constitutes a traumatic brain injury from a brain injury and I don't know, not to define it, but when you see it, right? But we don't know because we're laymen. We don't understand how that works. How would you all define that?
There's a lot of different terminology that's used in the research and different guidelines. So it kind of depends on who you talk to and kind of what field you come from. But in our children's hospital, we focus very much on the neurological side of things. And so to us, a traumatic brain injury is a TBI that is a result of a jolt, a bump, or a blunt trauma to the brain.
Okay.
And it can impact the skull and actually called a skull fracture in addition to trauma to the brain. And then it's really graded off of severity. So the one that we're most commonly think of is a concussion, right? A concussion more notoriously is linked with a mild TBI.
Okay.
That's a level of severity that really corresponds to that there was no bleeding in the brain, there was no skull fracture to where the injury was, and then it really goes off of the child's symptoms and their signs. And then from there you have moderate and then severe TBI, which are much more critical. And then really just changes the landscape on how we go about identifying and recovery for that patient.
Okay. And then going through that, I'd like to, because you've already worked, you said you were working for several years in the athletic area. So you've seen children come in, pediatric. I would love for you to give me a case study or two. Just give me an example of like, well, this person who was 3 years old came in, this is how they got the injury. This is how we walk through it. Just anyone that kind of sticks out in your head. Because we all have those 2 or 3 cases that are like, oh man, I remember that case.
Yeah. So I think where I'm probably, most of my experience, they're kind of big kids, right? They were like 18 and 19 years old, but that didn't change sort of the seriousness of it. So in the kind of athlete world, sports concussions are oftentimes considered a little bit more on the mild TBI realm. And so with those patients, I distinctly remember again having an 18-year-old kid, and we think, well, he's an adult, but I still had to pick up the phone and talk to mom on the phone.
Right.
And discuss, he's already had multiple concussions. When do we stop telling him he can play football? That's really crushing for a D1 level athlete who has aspirations to go to the NFL draft. And so what I remember a lot about that experience is how young brains, how neuroplastic they are, and that children or young adults or even adults can recover. It's about feeding the brain with that neuroplasticity and giving it stimulation in a graded progression. And so I got to work with him and actually did his vestibular rehabilitation. What that means is that we actually—
Vestibular. I remember us talking about that last time. And that is, now I love that word, vestibular nerve.
Yeah. So we actually rehabilitate the vestibular system and the eye movements to recalibrate, if you will, how the head and the brain adapt for quick movements. And so I got to work with him and I got to do some really fun stuff in his rehab that when we think about physical therapy, we think, maybe in a therapy room with maybe a yoga ball or something, but you can actually adapt it, and you should adapt it for the patient. So for a kiddo in sports, and like him, he was a running back. And so we did more running back like type of drills, and I'm not an athlete at all. So for me, I just leaned on his athletic trainer and I kind of, provided more of the science behind it. And it was really cool to see him really recover. And so even though he was 18 and considered an adult, he's still a big kid.
Right.
And he's someone's kid. So that was really fun to see him actually recover and recover correctly. A lot of our research has shown in that realm that children with concussion, especially sustained at the elementary and middle school level, they're really not managed for concussions well, and they can continue on to high school, maybe even college level, and have persisting visual and vestibular deficits.
Oh my goodness, yeah.
And they kind of just live with it. And I saw that a lot. And what we don't realize is that we can actually rehabilitate that through PT and OT, and even speech therapy when it's more cognitive. So it was really fun to almost like undo a lot of bad stuff that had happened to him.
So you can undo it from years before.
So
that's the brain. I'm sitting here thinking, give me some specific examples of what you do in rehab. You're saying that when you're stimulating, and what exactly are you doing during the rehab process?
So in concussion rehab, it can be a multiple of ways. You can look at more dynamic gait and balance. You can look at more visual ocular motor, which is really what I look at. And so the most common findings after concussion is a big problem what's called convergence deficiency. So what that is, our ability to pick up our cell phone and look at and text while we're walking in the hallway and look up, at the teacher or look up at someone talking to us. We don't realize, but that's actually ocular motor, which means ocular and then muscle movement.
Right.
That's often disrupted after a TBI. And that's what leads to blurred vision. That's what leads to headaches. That's what leads to dizziness. And so you can do very simple, we call like pencil push-ups, which is just like kind of bringing in a pencil and kind of pushing your eye muscles in and out. And then we can make it more fun based on the kid. So I've actually, with athletes, done even just like, I have a tennis player, for example, and I'll hit a tennis ball, and I'll change the distance so that they have to adapt their eyes for close distance of the ball versus far.
Okay.
So that's where it's fun for me, because we can take the therapeutic approach and really tailor it to the patient, the kiddo. And then they get into it, and then the athletes get competitive, and they say, well, I have to beat this. This is easy. This is easy. I should be able to do this. So I really love working with pediatric TBI, and I really love working with sport injuries, because those are often the kids that, are really motivated.
Got skin in the game.
Yeah. And they're really motivated to get back to where they were. And when you talk about recovery, it's not just, oh, I feel better, but am I as dynamic or as, have the same agility, the same sport performance that I did before. So that's kind of my experiences since coming to Children's and starting our program with our, our medical team. It's been a shift, because now at El Paso Children's Hospital, we focus a lot more on complex TBI injuries. So beyond just the sport injury, we're talking about children with skull fractures, children with, subdural hematomas that have, bleeds in the brain, children with facial trauma, children with seizures.
Right.
And so it's been really interesting to be able to now look at a patient from a more complex medical angle. And I always joke, I wish Dr. Makushi was here today. I know he'll watch this and laugh, because on our clinical team, he is very much a neurosurgeon and very much like, protect the brain, you should stop playing.
By the way, he's in surgery, and that's why he's not here.
Busy.
Just thought we'd tell the world, because sometimes things don't just stop. You know, it's
exactly.
just like, you gotta go.
But he's quite pragmatic about
Yes.
things, and will tell a kiddo who really probably thinks they're going to go to the NFL draft, like, you should just pick another sport to play. And then I have to go in there and say, well, he really meant was, know. And so we
and
always
then you gotta tell mom and dad too.
Yeah.
That's a whole other thing.
So we always joke about how we have a really good balance of a medical team that looks at this very seriously, that this is repeated impacts to the brain and what that can do over time. And then you have us on the rehab side that say, okay, well, let's work with what we have, and let's try to also retain functionality, activity of living, but also, satisfaction in functionality. And so I think that's one of the greatest parts about our team, is that we have all the different players, and we all kind of speak up and say, well, what about this? And again, we joke about it because, he's a surgeon, he sees the worst, and then I see the best, right?
Yes, exactly.
So it's been a good dynamic.
So here's a question that probably every parent is asking, and maybe you can't answer it, and I completely understand that, and maybe you can say why, but how long is it going to take for them to get back to normal? That's probably the question you get a lot. Mm-hmm. How do you answer that? I know that there really isn't an answer, because you won't know until you go forward, but because you're faced with that question a lot, how do you deal with it?
So one thing that we always tell parents too is, normal is relative. Mm-hmm. So a normal brain, none of us walk around and know what our normal brain looks like. In concussion and in TBI, unless it's pretty severe, we have indications to do imaging, CT or MRI. We're not really taking pictures of the brain. We're really going off of signs and symptoms. Mm-hmm. But what's important when we talk about normal is, or how long will this take till they're normal, is to do a really good assessment of what was pre-morbid. What we do a lot at Children's in our clinic, as well as in the ED as well, we're trying to standardize to which we're asking the same questions to every single trauma patient, head injury patient, where we're asking, questionnaires that have been validated that look at symptom inventories, which are important.
Symptom inventories.
Yeah,
that makes perfect sense when you say it out loud.
So we're not just kind of willy-nilly asking some questions, but we're actually addressing all the symptoms that can happen after a TBI. And then we have to ask, is this different for your child? Mm-hmm. A lot of our adolescents at this stage have premorbid mental health conditions. They have ADD, ADHD, and they might even have substance use, misuse or disorders. And if you just look at that in itself, sometimes those symptoms can almost mimic a concussion if there was a bump to the head. And sometimes, and more often, it exacerbates it, or it changes the trajectory of how they recover. Mm-hmm. So us having a really good assessment of what is normal for your kid, and now we have a bump, jolt, or blunt trauma to the head, and now something's changed.
Right.
That's what I look for. So doing assessments like that as a baseline, and then assessing, are we getting back to that baseline? That's the right way to do it. Mm-hmm. As far as timing goes, you're right. I don't typically say it'll take this, and this. We go off a lot of the CDC guidelines and heads up programs. So if a provider is interested in getting more information, that's what we go to. Mm-hmm. And so when we look at that research, it's been shown that for a mild TBI, in those instances, 80% of children are going to recover within 1 to 3 months.
Oh my goodness,
So that's
that's quick.
the stat that I give parents. And I think that, and it's really important for healthcare providers that we are sharing that narrative. There's a huge misconception, and back in, probably maybe 12 years ago, before different guidelines came out, that after a head injury, children need to be in a dark room, not be on their iPads, not be, doing anything. And that's really not the guideline anymore. We are seeing that there's actually better neural connections being rebuilt when we actually provide low levels of stimulation and then progress it in a graded way. And we just really rely on the kiddo to give us the green light. Okay, now we can go a little bit longer. Now we can do this a little bit more. But we don't want to avoid. We don't want to avoid physical activity. We don't want to avoid screens. We don't want to avoid noise because we don't live in a quiet and still world.
Right.
So we have to kind of provide a little bit of that stimulation. And that is what I have found parents are shy away from. They want their kids to rest. And I have to undo a lot of that fear and say, look, in 1 to 3 months, your child should be fully recovered from this if we do X, Y, and Z, and if we control for the pre-morbid conditions of X, Y, and Z.
So I'd like to have a question, and I almost feel like I'm asking you to repeat what you said. I don't, but now let's take it to, we're not sure, somebody bonked his head. Say there's a 13-year-old who bonked his head really hard, but nobody really noticed. He's at home right now, he's feeling what? And I'm saying that because sometimes somebody starts feeling bad and doesn't realize, oh, this guy maybe has a concussion or something happened. What can parents and or the people that have it be looking for? Like, what are the symptoms before he probably has a concussion?
Yeah, it's a good question because there's a misconception too that you are supposed to see symptoms right away after a jolt, bump, or trauma to the head, and that isn't always true. Sometimes it takes a few hours, even a day or two, to present itself.
Okay, yeah.
So I would say that probably the ones that I, clinically as well as the research indicates is different. So you have kind of your red flag signs, and you have kind of more of your subtle signs. I would say the subtleness has a lot to do with the vestibular system. If they're reporting dizziness, headache, clumsiness, discoordination, that in itself will tell you, and they're not typically like that, that in itself will tell you the disruption to the vestibular system. And in kids, that's not common.
Right.
There's always a reason for it.
Right.
And so that would be an indication. So any clumsiness, any falls, any report of headache, and dizziness.
So years ago, and I'm going to interrupt only because it stuck in my mind. Years ago, it was talking about if a child appears like he's drunk, and obviously he's not, as you know, but if that's the appearance, and I'm just trying to visualize this or have people who are listening be able to visualize that's kind of
to some extent. Yeah, I think it can look in different severities. But what you might notice too is a lot of positional dizziness. So kiddos who are getting up from bed and they're like, oh gosh, I'm dizzy, right? As the older you get, that kind of happens, but just, as you get older.
Every day.
Yeah, you need more time to get up. But young kids, they don't do that. And so positional dizziness will give you a good indication. Bending over to tie your shoe and then taking a minute to kind of come back up. That could indicate vestibular. Could also be more autonomic, which can happen after concussion, just kind of dysregulation with blood pressure and that kind of thing. But of course, the red flags, this is oh my gosh, we need to go to the ED right now, is any indications of them really difficult to be aroused. So, sleep, sometimes these kids crave sleep. And again, the myth was don't let them sleep. But if they're sleeping a little bit more, you want to watch them. But if you can't arouse them and can't wake them up, we've got to get to, immediate attention, medical attention.
Okay.
If they have a seizure, immediate medical attention. Complete disorientation.
This is great. Describe what seizures can present as, because some seizures people think, but a seizure could be very quiet and still as well. So maybe, I love that you said the word seizure at that moment. Describe what seizures can look like, because there's a whole variety of ways that a seizure can present.
And I wish that we had our Dr. Ali Melendez-Dozidi here, because she really is the expert in seizure and kind of what it presents like. So I don't want to misspeak and say what it could. I think you're right, though. A lot of times this seizure can look very, classic of how we see seizures with kind of the movements. And sometimes they're kind of quiet and silent, and maybe it's just a change in their overall, their dazed and confused.
Like almost slumped over.
And a blank stare.
Yeah.
So anytime I would say this, anytime that your kiddo is not acting themselves in terms of physical or even kind of like cognitive engagement, we can't rule out something more neurological. And that's when we go to the emergency room or seeking your PCP if you can get in that day.
So we're talking about now, I'm 59 years old, and I say that often because I think about what I remember when I was a kid in high school. Concussions were probably happening all the time. So now we are hyper aware of that, which is fabulous. But I'm thinking in my day when I was in high school and nobody treated concussions because nobody really knew it was a thing, you bonked your head, go sit down for a while. What do you see the difference of not being treated versus now that you are treated? So if someone just misses it and it's been missed for months and months and months, what is the outcome? And again, let's go to 13 years old, because I feel like that's a kid, but it's not a kid. It's like it's somebody in the middle, right? It's like everything's still growing, but they're probably not going to say anything because they're embarrassed or whatever. What are the big differences in outcome versus treatment and non-treatment?
Well, maybe I'm biased, but I can distinctly tell the difference. So in a child who maybe has a misdiagnosed concussion, and now we have spent more than those 3 months, right? So now we're past the acute phase, we're past even the subacute, and now we're kind of hitting these chronic TBI-like symptoms. Sometimes physicians will classify that as post-concussive syndrome. And whatever you want to call it, essentially what those children look like are what I would consider to have more severe, but more kind of either mental health, a lot more vestibular issues. Because what happens is that in some instances, if the injury was significant enough and the kiddo is not an athlete, for example, they might adapt now their everyday to avoid feeling a certain way. So if
it's that now their new normal? Is that what it is?
And I see a lot more an effect on their mental health, on their overall social, desire to be social. There is some research to show that, repeated concussions that are untreated, especially in boys at a certain age with past history of ADHD, ADD, that can lead to early indications of engagement with substance misuse. So there is this tie here, and that's where I think rehab is so important, and early rehab. When I see children who we can get in quickly, we can ID the concussion or the TBI quickly. We can get in with interventions quickly once we're cleared to do so. Those are the children where their brain takes over, that neuroplasticity, and that they can get back to doing what they enjoy doing. Going to school is incredibly important. Children who stay home from school or are homebound for, mild TBIs, that is really a detriment to their ability to recover from the concussion, but also reintegrate into everyday. And we see that often where kiddos who have been at home, for 12 months, have missed their whole sophomore year of high school.
Yeah.
And now we're not so much dealing with a concussion or a TBI anymore.
Yeah.
The brain has likely done its healing, but now we have a lot of psychosomatic, we have a lot more functional learning differences that, and behaviors, I should say, that have developed because of.
Right.
So we see a huge difference, and that's why our clinic and our hospital has a big push on identifying children earlier, managing them quicker, and integrating all of the disciplines. So we're all looking at it with our own lens.
Right.
Managing TBI for a pediatrician is a lot of work. It's a lot. And so that's really where us as specialists come in, and we can say, let's help you out and let's give some recommendations. And that's really the premise of our concussion clinic at Children's too.
So I want to keep going back to this because I know we say vestibular a lot and we've been talking about it, so we know what that means. But explain vestibular to the audience. It's like the central nerve balance. We talked about this in the last show too, because you educated the heck out of me on this on the last program we did. Yeah. So maybe if you were teaching a class right now, professor, as you are, assistant professor, but professor, how would you describe the vestibular system, so to speak?
So I'll first say vestibular does not equal balance. Balance is a multimodal system that encompasses your eyes, your inner ear, vestibular system, and then your sense of touch, your proprioceptive system. And after concussion, balance can be disrupted. So what we have to do is unpack. Is it vision? Is it somatosensory, or is it inner ear, or a combination of them? Vestibular is actually more related to how the inner ear picks up signals and then sends the signals up through the brainstem to your eye muscles. So the vestibular ocular reflex is traditionally what is affected from any vestibular injury, but often after concussion. And what that is that it's a reflex. It's very fast. It's like 8 milliseconds. None of us in this room will ever think about our VOR because it's just working for us in the background. So an example is if I whip my head around quickly, my eyes don't doom, doom, doom jumble. They actually stay fixed on you. And if they jumbled, then I would feel vertigo, just like you would feel if you were dizzy, something happened to you and you were sick, that sensation. And so this is a pathway. It starts off with the inner ear that senses movement from your head and tells your brainstem, oh, we're making a left turn or a right head turn. And the eye muscles counteract that. That reflex is fast, it's efficient, and it's to protect us. But after concussion, it's the integration between how quickly that signal is taken to the eye muscles. Sometimes the eye muscles are just sort of weak in terms of how they receive that information, and that's how we rehab it. So nothing structurally wrong. Oftentimes, and it can happen where you can have damage done to the inner ear from a blunt trauma that was really significant. More often than not, in a mild TBI, it's just a processing issue, a calibration issue, if you will.
I like that word.
So with rehab, I'm really training the VOR. So I'll have my patients move their head around while they focus on a sticker, or I'll have them catch a ball.
Now as you're saying that, I'm like where are my eyes going?
They'll catch a ball, that I throw up in the air, and they have to look for it. So we can recalibrate that VOR pathway. But oftentimes when I'm working with, especially my athletes, and I'll say, okay, I want you to move your eye muscles and I want you to do this, 10 reps. They look at me like, are you serious, lady? I bench press this much, or, this is my older athletes.
It's important, I promise.
But these eye muscles are incredibly important, and a little goes a long way. So the vestibular system is really that connection between the inner ear up to the extraocular eye muscles, and that goes through the brainstem and the cerebellum.
Okay. It's so beautifully explained when you say that. And I'm just trying to think too, let's go away from concussions for a while and talk about some other brain injuries that can occur and how they may occur that aren't concussive, so to speak, and how you treat those as well. So you mentioned seizures earlier, and that could be maybe not at all related to a concussion or a sport injury, but take that opposite route.
So in more just traditional kind of brain injury, other things that can cause dizziness or...
Can cause dizziness or can cause whatever it is that would land them to come see you.
Got it,
To have you help them. Not normal, that's a terrible word. Get to where they can start functioning better and better.
I would say that my clinic, from a vestibular standpoint, is 90% migraine headache.
Oh, wow.
And now becoming a lot more concussion.
Really?
So
totally would not have thought that.
And I say, that kids are not often the ones that report dizziness in the sense of the inner ear. So when we think about, you might hear this, I'm dizzy, and your doctor says you have an inner ear problem. 90% of the time, that's actually not true in a child. Unless children have a reason to have an actual insult to the peripheral inner ear organs, whether they have hearing loss or there's something congenitally wrong, or there's a tumor, it's about 10%, maybe less than that. The majority of my patients are coming in because they had a concussion, now they're dizzy, or they have the starts of vestibular migraine or a type of migraine that it makes them incredibly motion intolerant. They are triggered by visual motion, which uses their extraocular eye muscles, that VOR, vestibular ocular reflex. And so I'm assessing their vestibular system to make sure that it looks good. The signal can go all the way through. They're probably...
So stop there. When you say that, make sure it looks good, because I'm thinking to myself, when I get headaches, would be a day, honestly, like today, and no offense to the lights in this room, but these kind of lights really affect me. And then tonight, within an hour or so, I'm going to get that funky, and I call my light headache, it's from lights. So when what was the question I was just asking? I forgot what I was just asking. Goodness gracious. So when you're looking at lights, when it's a headache that comes from that, a vestibular headache that can be brought on by lights, is that how do you know that when someone's very young? Like, how can they tell you? How do you know what's causing those?
Vestibular migraine in childhood is a relatively newer diagnosis. And it actually, my experience now has seen that it looks different in the neurology world versus otolaryngology world. And that's the world that I come from. So in the otolaryngology world, pediatric vestibular migraine is actually well adopted and well accepted as a likelihood to explain dizziness in a child who has completely normal peripheral inner ear function and who has a history, indications of possible migraine. So in a young child, we call it the vestibular march. Okay. And the vestibular march is at a young infant by about 24 months, that VOR, that vestibular reflex, is fully maturated, but it's not fully, reliable until about age 4. So this is the kiddo that you put in the car and they throw up in the car. The motion sick kid.
Right.
And when you're in a car, your inner ears are telling you you're moving forward, but then you've got everything going backward and you have a visual conflict.
Interesting.
People who have migraine traditionally, more vestibular migraine, that's their problem, is that they have a really high reliance on their visual system. And if that isn't stable, it can trigger dizziness, nausea, motion sensitivity issues. So the vestibular march starts with them, and then those kids might develop kind of like abdominal migraines or abdominal issues, stomach aches, vomiting. And then once they hit puberty, and it's more prevalent in girls, particularly as they start to get into the years of kind of menstrual cycle and all of that, we see a peak now in actual associated photophobia, which is sensitivity to that light, phonophobia, sensitivity to sounds. They could have tinnitus, which is ringing in the ear. They could have perceptions of hearing loss. And they could plus or minus have head pain. That's usually like unilateral, kind of one, behind the eye or kind of one area. And there's all different ways to diagnose migraine, and I'm not the expert in that by any means. But in our field of audiology and otolaryngology, when we see a patient present for dizziness, they usually go to the ENT, and the ENT is like, this isn't ear. Then they come to me, and we go through a series of vestibular tests to make sure that all of the ear works fine. And then we look at how well they're able to track lights or follow lights.
That was my question. Okay.
And I can usually see within kind of that area that they're really sensitive, and they can do it, but they don't do it well, or it triggers a headache.
Right.
And that in itself already tells me that that they're triggered by visual motion. We go off of the International Headache Classification Diagnostic List for vestibular migraine in childhood. Okay. It's relatively new. I'm still learning a lot about how different, fields accept that or not.
Yeah.
But if you ask me in my clinic, when I get a referral for dizziness,
you're going to check.
50% of the time, I always ask, do you have headaches or migraines? Does your mom or dad have headaches or migraines?
Interesting.
Do you get sick in the car? We're asking a lot of those questions that may lead us to think of that vestibular march. So, that infancy, kind of abdominal issues in earlier childhood, now it's migraine-like, that usually goes along with hormones.
So here's another question. I'm just thinking my motherhood, when I had younger kids, and if they don't know the difference because they've always had vestibular migraines, maybe they've always had these headaches, but they're so used to them, they're not going to complain about them. How do parents come to you with smaller ones that may not be able to, describe what's happening? How do you find those, or what are some case studies of parents saying, I don't know, I'm just trying to figure out, how would I know that my child is having issues?
So a lot of times in younger, because you're right, they're not usually going to be able to report that.
Yeah.
But in young kids, it's usually like a delay in their gross motor skills.
Okay.
Walking, standing. It's also an apprehension. Those are the kind of the fearful kids that don't want to go down the slide. They're the kids that throw up a lot in the car. They're the kids that maybe are more clumsy and fall down a lot. Usually that's kind of what will make a referral initially. And a lot of times those referrals go to neurology, and they should a lot of times. You want to be sure that we're making sure it's not something more severe. And so they'll do imaging and kind of rule that out. And that's how that patient gets to me. But you have some kids that are a little bit older that will verbalize in their own kind of, way that, oh my gosh, I'm dizzy, their room is spinning, and they might vomit a lot. So I get a lot of referrals from otolaryngology that come that way, because right now it's still kind of common practice to associate vertigo and dizziness with inner ear.
Okay.
So that's kind of how I would get them. But you're right, it is hard for kids to report that. But in the migraine kids, they actually, it can be very debilitating depending on the kiddo and depending on kind of what happens. So, you know, it's a newer field within what I do, but it's really, really prevalent.
Okay. I'm going to ask you to step out of your comfort zone. And if you don't want to, just say, let's step back somewhere else. So we had a neurology surgeon that was going to be on the show, but he's in surgery.
Yes.
So if he were here, what would be some questions that you would ask of him, or I should have asked of him, that you might be able to answer, even if it, and I will, full disclosure, I know this is not your area of expertise, but you said earlier, and I love it, that we're a team. Like, we talk to each other. This is how this happened. This is how this happened. So what might be some of those questions that you think could be, you know, shining a light on that?
Yeah. So for Dr. Zaid Makushi is our pediatric neurosurgeon. And I would say he, as well as even our pediatric neurologist, Dr. Ali Melendez-Zidi, I feel like they get a lot of our patients like want to see them. I could be like, you know, on the sideline or whether they don't care about me, but they really want to see those two, or at least one of them, because I think it gives parents a sensation of feeling like comfort. Imaging, MRIs and CTs can be very comforting to parents, even though for certain instances in traumatic brain injury, it's not indicated to scan a child. I still find that parents really want to have that.
It's the assurance thing.
It's the assurance thing.
Yeah.
And I think I see a lot of times where parents will ask more of our medical team of, when should they stop playing a sport? Are they ever going to kind of go back to normal? What
test can you make to tell me when to stop playing?
When to stop playing, or, you know, what does their brain look like? And I think I would be safe to say, again, I don't want to speak for Dr. Makushi, but I think it would be safe to say that imaging, MRI, and CT are indicated when we suspect that there is a brain bleed or even a skull fracture. And we have signs and symptoms clinically that make us think, oh, we need to put this child through, you know, a CT, a head CT, or, you know, MRI, a cervical MRI. But I would feel that a lot of parents kind of would want that as a check mark.
Yeah.
And what we have to remember is that with MRI, particularly when we look at the brain, we really can't diagnose a concussion by looking at an MRI.
Right.
There is a lot of research in fMRI, functional MRI, which is being used in research, and even DTI, you know, diffuse tensor imaging. That is,
so describe what those are.
So in a sense, those are looking more at the kind of connectivity pathways of the brain.
Okay.
So when we do an MRI, we're really looking for tissues and fluid and things like that to make sure that there's no swelling and bleeds and things like that. But in the fMRI and DTIs, that's kind of still on the forefront of research of, could we diagnose a concussion if that connectivity or that activity in this part of the brain lit up differently than the other? So it's exciting. But as they say, there is no pregnancy test for concussion.
Right.
There is no pregnancy test for traumatic brain injury. It really is a constellation of signs and symptoms and, when indicated, imaging. But I think a lot of us get asked that question of, I had a patient just, you know, today that was like, I really want an MRI and it wasn't indicated. And the neurologist said the same thing. It's not really indicated. So we have to try to find line. I think of wanting to, I think the question a lot that still needs to be answered is, when is enough enough?
Right.
What does repeated head impacts do over time? I think that would be an interesting question to kind of get from the sense of more of the medical side. There are physiological changes, microvascular changes that do happen to the brain, but on a first scan of a MRI in the ED, no one's looking at it at that level. We are ruling out the severe things because that changes the pathway. So I would say that's a really common question that those guys get asked. And those parents are really wanting to kind of get like that picture, right? I just came from my OB appointment. I want an ultrasound. I want to see the baby.
Right.
So I get it. I actually really get it. But we have to have a really fine line of what is standard practice, what is evidence-based.
Right.
And
not just what's going to make you feel comfortable at any given time.
Exactly.
Yeah. I know we have some prevention strategies here, and I know sometimes you just can't foresee that. And we've been talking a lot about concussions. Let's talk about, if it's in your purview, and if not, let me know, but let's talk about a car crash. Now we're talking concussion, but this is like a major injury. There's blood, there
motor
might
vehicle
be
accident.
some skull issues, there's, et cetera. Throw anything out that you may have worked with before that might help pertain to what we're talking about now.
Yeah, so I've talked a lot about sports, but motor vehicle accidents and those ATV accidents are a big one. And I think I've seen that a lot here in El Paso as well. We have a lot of kids who want to get on the ATVs and go around the desert. And that has oftentimes leads to pretty significant trauma. That can lead to a skull fracture. That can lead to hematomas, subdural hematomas. That can also lead to a lot of cervical fractures or changes. So we actually had a patient in our clinic that was in a C-collar and, in a brace, in a spine brace, just from an accident similar. And it changes the seriousness of the conversations that we have, but it also changes the therapeutic approach.
Yeah.
Right. So a kiddo who does have a skull fracture, who does have a hematoma, who is in a cervical spine, a C-spine for a reason, for a structural reason. And we, as the therapy side, we can't go as fast as we want to, or we would. We have to really think about intracranial pressure. We got to think about, mobility. We can't just have the kiddo move their head up around like I want them to and catch a ball. So those instances change our therapeutic approach. And while the recovery might go a little bit slower, it is safer.
It is safer.
It is safer.
Tell me why. That's counterintuitive in my head.
Yeah, if the brain injury is more than a mild TBI and there was a skull fracture or there was a brain bleed, we don't want to increase the heart rate so much. Like go have them do lifting things.
I get you.
And then have them have an increase in intracranial pressure. If our neurosurgeon has them in particular brace of some kind and our spine surgeon or something, and we're as rehab therapists, we want them to be moving around, we could damage the surgery they just did. We could put them at risk for something, nerve injury, things like that. So it changes their recovery, but it's a safer approach for them.
Okay. And if you're looking at El Paso Children's, right? So there's coming from all over the region and the Borderland, et cetera. What are the most common? I know you said ATV. I feel like a couple of years ago when the Razor scooters were first a thing, there was a bunch of those. What was it just recently? We were just talking about ATVs, car crashes, not so much bikes anymore. But in general, what are the most that you see? And I'm saying this also in the world of prevention. Like ATVs, wear a helmet. You think you're in a buggy looking thing. Why would you wear a helmet? But
scooters. Those motorized scooters actually are really common without helmet use. This might be really funny, but even like dogs coming at you, like those pit bulls.
No kidding.
Especially little kids, and little kids, the thickness of the bone is different. Their brain is still very much developing. And so they're more susceptible to more severe injuries with smaller impacts. And so falls, kiddos that just fall from the back of the couch, or they're crawling and they're near their bigger dog that comes at them and it's no one's fault. It's just collision. We kind of see it all. And sometimes you're like, how did that happen?
Right.
I would say from a prevention standpoint, we actually see still quite a bit of scooter, bike accidents without helmets.
Okay.
That seems to be when it's not sport related, that seems to be one of the bigger ones.
Okay. So now I'm going to ask you as going to be mom. You actually are a mom already, by the way. So I started looking at things very differently when I was pregnant. For example, I was learning how to ride a motorbike. Like I wanted to be a motorcycle girl. And I got pregnant and said, I stopped that completely because it just freaked me out. Yeah. And I want to talk about motorcycles for a minute because Dr. Tyrock, who's here every now and again, he always brings up traumatic brain injury with motor crashes. He says, they're not accidents, Kathrin, they're crashes. Yeah. So when you see a helmet, somebody was wearing a helmet, yes, but there's still a traumatic brain injury. And this may be, people can drive motorbikes from the age of 12 on. What have you seen in that type of a traumatic brain injury? And when it is a life or death situation for a while too, once they're past the danger of not being alive anymore, once they're past that, how long does that process take? Or what? Maybe the question would be, what are some of the very first steps in rehab when you have like a major crash and things are just, thank God you're alive.
Right.
Now, where do we go from here?
Yeah, I think a lot of those individuals would likely be more on the, moderate to severe TBI realm. Those are the kiddos that are probably admitted straight from our ED to the intensive care unit, the PICU. And you're right, it's about stabilizing them. We want to prevent more bleed. We want to prevent a lot of issues that might come up when it's probably more significant like that. That really relates to the level of the impact, the level of acceleration, level of the impact to the brain, the skull, all of that together.
Right.
Even
and when is the damage
cervical
permanent?
spine.
You know, I guess that's kind of what I'm trying to ask, but it's a hard question to ask.
Yeah.
Like, when is the damage to the brain permanent?
I think that's really hard to say.
Okay.
I think it's really hard to say. It's really based on the patient. It's based on how many prior injuries they might have had, if it's something related. Yeah. Rehab, though, in that instance would start very, very slow. And so we wouldn't be too focused on doing a ton of, upper mobility issues. It actually might be a bigger focus on the cognitive side. Can they swallow? So our speech therapy, kind of group, cognition. We use different grading scales as well to assess cognitive status and alert and mental status after a brain injury. And that gives us a better indication of kind of where they're at and what that recovery will look like.
Right.
So a lot of times when it comes to a severe TBI, vestibular people are not in the room, right? We're not too focused on that. It really is making sure that patient is stable and probably working a lot more on their cognitive and mental alertness to be able to kind of get them starting with that. Those are the patients that have a very, very long recovery. Sometimes those patients require more inpatient rehab therapy, or they stay kind of on different therapy that's more like neuro intensive. So they get therapy multiple hours all day,
Right.
sometimes a week. So that type of brain injury really necessitates longer recovery and probably much more intensive neuro rehab.
Okay. So I like how you said that too, intensive neuro rehab. And I'm thinking to myself, the brain has this beautiful way of healing itself with your help. And maybe if you're able to explain why that is, because I think neurology, right? Like nerves are so like crazy cool and they can regenerate and they can reproduce here. And how does that work in tandem with what you're talking about? So it's not rewiring, but it's kind of like rewiring.
Kind of is. It's rewiring, it's neuroplasticity. It's trying to use what it had before to remember, whether it's muscle movements, it's reflexive movements. Again, it's like things like swallow. It's things like, handwriting, motor movements of the hands. Muscle memory is really important. And like nerves are like muscles in the body. And so if we don't exercise them and utilize and provide that stimulation to them, you have a higher risk for, reduced neural integrity and health. And so that's the reason why we might do more intensive rehab, is to provide more consistent and more long-term rehab up front. When we discharge a patient and maybe don't give the correct instructions of what to do when you get home, you have a higher chance of those patients becoming pretty sedentary and not exercising those neural connections that are important. And so we lose time.
Yeah.
In a younger child, it's even better because we want to really maximize that young, healthy brain. In older adults and traumatic brain injury, that looks different. And so for young kids, which is the reason why I only work with children, is I love how they recover. You kind of have that added benefit. As long as we give it to them, they can recover in sometimes a lot more of a faster way. And it's all based of, neuroplasticity. And brain, everything wants to grow at that point.
We're kind of nearing around 10-ish minutes. So what I want to do is like stop asking questions, because this is my favorite part of every show, is what you in the field, you're out there all the time. You're getting education, you're going to conferences. What do you see coming up in the future in maybe the next 5 or 10 years that you're excited about? Like you talked a little bit about some stuff earlier, but that's always fascinating to us, because doing this exact same show in 5 years might look very different because of what's on the forefront that we don't see just yet.
Yeah, I think for sure in the realm of concussion or traumatic brain injury, man, we really, really want to have some like more definitive biomarkers, right? Objective measures that tell us, again, that pregnancy test for concussion. What we have found here in the Borderlands, and I think a big push as to why we're talking about this topic and why El Paso Children's and why Texas Tech physicians, like we're all trying to become the mecca, the center of trauma and pediatric TBI, is because in these areas, there's a lot of misnomer. There's not a lot of that cool research that we see in the East Coast here. And so you don't know what you don't know. And if you've been a physician for 70 years, and you've been practicing in a certain way, it's really hard then to kind of what's new on the forefront with this. And so our job at Children's and our job at Texas Tech Physicians is to be able to deliver that education to the community, to doctors, to therapists, all that stuff. And the more that we know, the better that we will all be at creating equity in how we're diagnosing traumatic brain injury, how we're managing traumatic brain injury. So while the research and the kind of exciting stuff in TBI, at least in my world, is biomarkers, that pregnancy test, can we take a picture with the MR and say that is a concussion versus that's not? Yes, that is something very, very people want. But right now,
is it realistic? Do you think?
I think it's realistic, but I think we're far from it still.
Okay.
Because when you talk about biomarkers, you talk about, blood levels and things like that, there's a lot of variation, a lot of stuff that comes with it. It would necessitate huge clinical trials, which I'm sure they're doing. But it's also feasibility.
Yeah.
Those tests are expensive.
Right.
Does every hospital have access to them? Do we know how to interpret them? And that's what I mean by equity, is that may happen at some of these larger centers, but we have to think about our community here and what are we doing to make sure that we're not over-promising and under-delivering. And I think as a first step, what I already know will be short-term for our field and the world of concussion and TBI is this whole idea that we are no longer recommending sedentary activity after concussion.
Right.
That is something.
I love that you've said that several times this evening.
It's about quick progression, or it's about, quickly getting back into school, getting back to activity for the sake of earlier recovery and a graded progression. And if all of us can keep that mentality when we first diagnose concussions or work occupational concussions, we are doing such a better service to our patient than a biomarker.
Right.
Right. And it's cheap. It's free. And that's what I tell patients all the time. This is something free that you can do here right now that I already will tell you has already been shown in the research to benefit.
Right.
So,
and you're saying this too, so I'm thinking about you as an audiologist, and again, it's. I remember when I first met you, I thought, well, what in the world is that? So there is a team of audiologists around the country, if not around the world. And how often do you meet? What do you share? Because, like you said, it depends on how much money do we have in our region? Well, maybe in some areas of Europe, there's a ton of money, and they're researching this. Like, how do you guys keep tabs on all this and who's doing what and who's bringing what to where?
So
to me, that's exciting.
Yeah, interesting in audiology. I always joke, I'm like, what is an audiologist doing a concussion team? And that's fair because, well, what am I doing?
It's all about vestibular.
Yeah, but I think I'm a little bit of an anomaly just because of my experience and my really interest in concussion and my own personal research and search and kind of clinical work within it. Most audiologists don't work this deep into concussion or traumatic brain injury teams, so I see it as a luxury.
So people are learning from you.
Maybe, but more so than that, I think it's also showing that what we can contribute to the team, especially in our community where maybe we don't have access to 20 more types of vestibular specialists, how what we have can step up to the plate and serve that role. But I think in the field of audiology, how we're kind of all connecting, you definitely have your folks who are much more vestibular in nature. And we're the ones right now utilizing, eye tracking, utilizing certain types of objective measures to show that we're not just diagnosing concussions or TBI off of the symptoms, but we can show that something has changed along the ocular motor pathway. And that is likely correlated to head trauma. So that's what we're contributing to the field right now. And that's really why a lot of physicians will refer to me in that context.
And I'm just listening to you throughout this hour, as you're describing certain things, I'm like, I've had that feeling. They're fleeting. But then you kind of wonder too, people that have this all day, every day, and especially I think we could do an entire program on migraines because of all the different descriptions you were giving on how people get migraines, feel migraines, how they present, how they manifest, etc. So in that field in and of itself, because you hear, it's almost like a catchword. Oh, I have a migraine. Go in a dark room.
Not all of us actually have migraines.
Yeah.
No.
I have, knock on wood, when I do, I have I call it a light headache, meaning from light, but it goes away in a couple hours. But I know it's from this because I can feel it coming in right now. Driving at night, that happens to me too. So what do you see in the world of migraines? And I know it's not really per the show, but I feel like everyone in the world knows what a migraine is, has kind of felt like what a migraine. How do you see that world in the next 10 years? Because you're talking about Botox can help some of it, maybe not, I don't know.
And again,
just
I
in
think
general.
there's a whole like slew of people who are just migraine specialists, like neurologists that just do migraine. So I would, they probably have a lot more to say on that. I think in this part, I think something similar. I do probably believe migraine's probably overdiagnosed.
Mm-hmm.
Like
I think
you just
so
said.
Too. I hear it
like
all the
I
time.
I have a migraine. My husband is like, no, you don't.
Right.
Like,
different thing.
Yeah,
right.
but I want to express like, no, it's severe to me. It impacts me. It's significant to me. So I probably think that migraines are probably overdiagnosed, but similar to concussion and head trauma, there is no pregnancy test for migraines.
Right.
I mean, there's certain things you can look at, but it's, in my opinion, at least when I look at a child who may have vestibular migraine, I'm really going off of their signs and symptoms and their history.
Not off a CAT scan, MRI,
Yeah,
or anything.
really, or in my opinion. And so there's a lot of things that I think we as providers and practitioners, we have to go off of patient report, and that can be hard, especially in a little kid. And so, especially when you have worried parents, like you said, who see their kid and it's like, I just want them to feel 100% better,
right?
No pain.
Right.
And so sometimes, you can spend a whole hour. I can spend an hour just doing a case history on like their vestibular symptoms. So there's a lot there, but you're right. It's incredibly prevalent. Yeah. And I think it's exciting to be able to sort of now be able to deliver those types of even services though here in our community, because a lot of these kids were suffering, being sent out.
Right.
So, we're getting started.
Well, before this program started, we were talking to Daniel, who helps put a lot of this together. And it was like, you were the person that kind of brought all of this to the Borderland. So thank you so much for being here, truly. And again, the program that we have, because there's a couple of different ways that you can watch this program if you missed a lot of this evening. Sometimes you tune in late, etc. So if you tune into the show a little bit later, if you want to watch it again, there's 3 different places that you can access it via streaming. One is pbselpaso.org. Also, the El Paso County Medical Society website, which is epcms.com. And then youtube.com, and all of those sites, you can just type in the El Paso Physician. This particular program is called Treating Pediatric Traumatic Brain Injuries in the Borderland. If you just throw in pediatric brain injuries, that'll also pop up. But those are always nice to be able to go back and look at it. And don't watch yourself, because that's always, I
never do.
Good. We've had with us Dr. Amanda Chiao, who is the assistant professor at Texas Tech El Paso and pediatric audiologist over at El Paso Children's. Thank you so much for being here. You've explained so many different things. I'm Kathrin Berg, and this has been the El Paso Physician.
The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician television program to your home for the last 27 years on PBS El Paso. If you should have any medical questions relating to this program, you may email us at epmedsoc@aol.com, and we will try to have our experts answer your questions.